My name is Terry Mamounas. I'm a breast surgical oncologist. I'm the director of the Comprehensive Breast Program at UF Health Cancer Center at Orlando Health in Orlando, Florida. So the question of whether patients with BRCA mutations should have surgery immediately or at a given time is one essentially of preference. And of course, we have some data to support what we may want to do. As we know, patients with BRCA mutations are at substantially increased risk for breast cancer and ovarian cancer. The risk of breast cancer is estimated to be about 50 to 80%, depending on the study. Risk of ovarian cancer is a little bit less, but still it could be up to, I think, 20 to 40% lifetime. So we know that the lifetime risk is elevated for breast cancer, and we know that we have some ways of reducing this risk with medication. In some patients, those with BRCA1, for example, there's no such evidence to be able to decrease the risk of endocrine therapy. So what that leaves us with is prophylactic surgery or risk-reducing mastectomy for the breast and risk-reducing oophorectomy for the ovaries and the fallopian tubes. Now, when to have this surgery is a matter, again, of choice. We know that typically breast cancer doesn't occur in the teens or 20s, but most of the times with BRCA mutations, we see breast cancer starting to happen sometimes in the early 30s, 40s, 50s. So obviously the earlier, the better, because technically you don't want to have somebody developing breast cancer while you are watching them. On the other side of things, we now have, besides mammography, we have MRI that we can do 6 months apart. So we can increase the surveillance of the patients with clinical exam, mammogram, MRI, ultrasound. So if there was something to develop, at least we can try to detect it early. Having said that, though, for example, for BRCA1 mutations, those tend to develop triple-negative breast cancers, which are fairly aggressive and rapid growing, and sometimes those can present between even interval examinations. So that's what we call interval cancers. So obviously we have to be proactive. So I think typically there are a couple of things that sort of complicate these decisions. For example, childbearing and where the woman is at that part of their life. But as long as women are done with childbearing, then I think the time to perform a risk-reducing mastectomy is as soon as possible to prevent, again, a breast cancer from developing. So typically we let women to go through the childbearing potential if they want to nurse. And then, of course, we'll monitor the breast during that time. And then we then perform the risk-reducing mastectomy at the time of her choice. I must say I've done it for as young as teens, 19-year-old patients that they were very adamant about having the mastectomy and they felt good about it. And again, the patient has to be ready mentally to undergo this procedure. Otherwise, you can still wait. Of course, we have to talk to our plastic surgeons. They have to have consultations for reconstruction. If they wish for reconstruction, most of the patients are. And then when they're counseled and they're mentally prepared for this, I think the earlier possible would be the preferable approach. Usually we do the mastectomy first and the oophorectomy later, because the risk of ovarian cancer usually occurs a little bit later. There's nothing to say that it could not be done at the same time. We've done it as well if the patient is desirous of getting everything done in one setting. Of course, the oophorectomy has some adverse effects, such as, for example, abrupt menopausal symptoms, hot flashes afterwards. But having done the mastectomy and then the oophorectomy at the same time, so if there's no breast tissue, we can still potentially put them on estrogen replacement therapy and avoid some of these menopausal type of symptoms. So depending on the patient preference, we can do them together or we can do them sequentially. We usually do the breast first and the ovaries after, but there's no hard and fast rule. I've seen patients where they came from the GYN and already have had their ovaries removed and now they're looking at the tubes and ovaries, and now they're looking for prophylactic mastectomy. Another thing to stress to the patients is that once you have bilateral oophorectomy, that will reduce potentially the risk of breast cancer because it's a hormonal intervention, particularly if they have the oophorectomy in the 30s or early 40s, so they interrupt estrogen stimulation. So that's another potential temporizing measure if they want to delay the mastectomy for a later time. Having the oophorectomy helps. But this is in general how we approach these patients. But again, the patient is in the center of this decision, and when the patient is ready for that, we counsel them and then we do the surgery.